And good evening, everybody. We're delighted to welcome you to this webinar on understanding nephrostomies. My name is Liz Ogilvie. I'm a trustee for the Urostomy Association. And when I'm not doing that, I'm actually a facilitator. And because we're so delighted to see so many of you here today, we're actually going to facilitate this meeting. So we are very, very, very grateful to our sponsors. That's Vine. So thank you very much indeed. And we are hoping that you will get a chance today to learn an awful lot more than perhaps you do now, or refine your knowledge if you already know something. And I'm delighted that we have Paula Allchorne from Barts NHS Trust, and she will be presenting along with Lauren. And then we're going to have a chance to hear from you. We are not going to take questions and answers today simply because there are so many of you. So we have something called a Padlet. Some of you may have come across a Padlet before, but a Padlet is basically a wall where you can put post-it notes. And we'd like you to put your questions on there. After this webinar, we will cluster those questions together and we will answer them in FAQs. So if you could use that, that would be fantastic. It is very, very simple. You literally grab a post-it note, write your questions on. It also gives you a chance to transparently see all those questions. As you have done already, we will be muting you when you're in the main room. So thank you so much, everybody, for doing that. I don't need to say this now as often as I used to in the days of COVID. And thank you for those of you who've got cameras on. It is really nice to see people's faces. It makes so much difference. We don't care if you're eating supper, drinking coffee. It's just much nicer. It makes it an awful lot more human, and certainly much better for both Paula and Lauren when they're presenting. So thank you very much for doing that. If you need anything during the course of this webinar, then if you message either Scott or myself, you'll notice that we also have Samantha Sherrod, who's our chief exec from the Urostomy Association, and we have Brian Fretwell, who is the chair of the Urostomy Association. And they will both be saying something. I'm now delighted to welcome Brian Fretwell, who is the chair of the Urostomy Association. So Brian, over to you.
Okay, thanks. Welcome, everybody. It's nice to see so many people here this evening. And also to reiterate what Liz said and thank Vine for sponsoring this event tonight. So just want to introduce the speakers. We've got two speakers, obviously, Lauren from Vine and Paula, who's from Barts in London, the largest NHS trust in the UK. Paula's got 30 years of experience with all urology subspecialties. She's also got an Executive MBA in healthcare. She's been president of European Association of Urology Nursing and won 13 national awards, including a Gold Award for Outstanding Service to Nursing, presented by the Chief Nursing Officer of England. So we're very privileged to have Paula with us this evening. I should also mention, of course, that both Paula and Lauren have been involved with putting together the pathway for nephrostomies, which has been long awaited and very much welcomed. So better say a bit about Lauren, sorry. Lauren works for Vine and has a wealth of experience in urology. Spent 8 years working in the community care alongside a strong background of acute nursing, and she's developed expertise in supporting patients with complex urology needs. So over to you two speakers now to tell us all about nephrostomies. Thank you.
So first of all, I do want to thank Vine for hosting this, but also the Urostomy Association. It's been a great opportunity, and I've given a lot of webinars. Never makes it easy ever giving public talks, but actually to have over 200 people sign up shows the need for such a topic to be discussed, I think, and I think that's probably our biggest surprise, Lauren, isn't it? That so many people have signed up for this, so it's incredible. So thank you everybody for signing up. Okay, so I've been introduced already, so thank you very much for the introduction. And Lauren is the absolute expert because she works in the community and in secondary care, primary care and secondary care, looking after nephrostomies. I did close disclosures. So Nephrostomies, I mean, hopefully most people would know what a nephrostomy is. You're all on this talk today. It is a tube that goes into the kidney, and it's a thin tube. It's placed through the skin directly into the kidney, and bottom line is it diverts urine externally when there's a blockage. This is a picture that we used in EAUN, and I think it's really nice and simple and explains exactly what it does. Nephrostomies, I think, are always worrying from everybody. I think people worry generally about how to look after them. But I think we need to recognise, just seeing if I can move this on. That's it. I think we need to recognise the key reasons why we put nephrostomy in, and actually it's generally for life-saving often. So there's four main reasons. One is the clinical urgency. So like I said, this is for life-saving patients. It's for patients that have an obstruction or an infected system. The second group is for renal preservation. So obstruction, i.e. that's normally from a ureteric stone. The third group is oncological, and I think this is often quite a difficult group. It's whether everybody, and I'm going to say everybody, actually sometimes needs a nephrostomy. So I'll discuss a bit later on what the framework is, but we have said this is really important for an MDT because it's about patients' quality of life. So patients will have a nephrostomy in for oncological reasons to unblock their kidneys, but often to give chemotherapy. But whether this is the right thing sometimes, that does need to be agreed as a multidisciplinary agreement. And then fourth main reason is around fistulas, retroperitoneal fibrosis. So a group of us got together to write a nephrostomy framework. Why did we do this? Well, we did this because there was problems. There's national problems. Bottom line, do we all know how to care for the nephrostomy? And I think we don't, actually. And it's whose responsibility does this sit with? So we got together, so it's a multidisciplinary group of us got together to write the framework. It's taken a couple of years to actually write it. And the main reason was because patients were coming to harm. And I think that's really important. And why are they coming to harm? Well, I'll cover some of that, but we hope that the framework that we have published, which is on the Urostomy Association and on Bowel Association, frameworks published now, we hope that this will help people understand why they have nephrostomies, how to look after nephrostomies, and I'm going to say probably not be so worried about looking after it. It does give an overall whose responsibility is it? If there was a small group of you in here, I'd say whose responsibility is it to look after nephrostomies? Bottom line, it's everybody's responsibility, and I think that's where patients do tend to come to harm because I think people often say, well, it's not mine, it'll be colorectal, it's oncology, it's urology. So what we did was we thought about how big is this problem? And I think the problem with so many people on this line, I think that shows how big the problem really is. And actually the problem is patients are coming to harm. They do not know where to turn to. And they really do generally have a poor outcome and poor care if they have a nephrostomy. I'm not saying everywhere, but I'm saying, I can definitely give some bad examples from practice where I work. So it's how do we change this? We wanted to work out what, why, and how. And that's what are we dealing with? So there is no standardised care for nephrostomies across the UK. So that explains why patients are coming to harm. And there is a lack of ownership. And I'm going to say responsibility as well, because if no one's taking any ownership, they therefore have no responsibility over that patient. And I think that's probably the most important key thing. And everybody who's contacted me knowing this is coming out or wanted to contribute has said this is a key thing. Who does this sit under? Where does this sit? Why is it so important that we do something like this? I mean, 30 years I've been doing urology. No one's ever thought about it before, which is amazing. And I don't understand why we don't have guidelines for this. especially when we think about bottom line is poor patient experience. Whether this is, saving someone's kidney to end of life, it can be. Patients go in and out of A&E, sitting there. I mean, we know what our A&E is like at the moment, 7 or 8 hours waiting just for a nephrostomy to be flushed or dressing to be changed, or they just don't know what to do. Patients are caught in between primary care and secondary care. And I think, Lauren, I'm going to say you've definitely got some experience on this, haven't you?
Yeah. It's I worked in acute urology for a number of years in my local hospital, and I knew how problematic it was. And I'm sure everybody on this call, a lot of people on this call, have experienced similar things. But you'd get patients come back in with blocked nephrostomies that have been pulled out because of incorrect fixation, or they didn't have any dressing on, or a minimal dressing, or infection because they weren't seen by the right person in a timely manner. And out in the community in this role for the last 5 years, I've seen it from the other end as well. Poor discharges with incorrect information or no information. And I'm sure people can understand, whether you're community or hospital based, that happens, which is again why we create the frameworks, is clear guidance on what people should be discharged, what patients should be discharged with, which is going to be really helpful. And again, as Paul has been saying about responsibility, it's everybody's responsibility, and it's quite easy to pass the buck to somebody else and say, oh no, we don't deal with that. But we do, and as registered nurses or healthcare professionals, we should be taking accountability. And hopefully this guidance, again, when we sort of talk through it and everyone has the chance to look over it, is long, but there are little clips in there and links that will be sent out after this that are easy to access, that are really helpful for healthcare professionals and for patients. So
yeah. I think it's a communication. It's how do we improve our communication across different specialities and disciplinaries?
Yeah, absolutely.
So we got together a huge group of people. Most important, everybody thinks nephrostomy sits with urology. I'm in urology, and I sometimes it does, but sometimes it doesn't, and I think that's really important. Sometimes it will sit with gynae, it will sit with colorectal, oncology, palliative care. If the patient's a community long term, then it can sit in a community. But what we shouldn't all expect is it's everybody's responsibility. And I think that's what's so important. And that's why we made sure how to address this was making sure everybody was involved. Patients, charities, associations, district nurses. We've had everybody involved. And I think it's opened my eyes up to understanding community services much better, but also community service, understanding secondary care better. Lauren's in such a privileged place where she works in between both, but most of us don't. So I think that was really important. So the aim of the actual framework was to standardise care across the UK, prevent harm, avoidable harm, provide education and clinical guidance for new and existing staff, encourage timely escalation, and to really underline it's everybody's responsibility to manage nephrostomies. I've had many roles and worked in many hospitals, and it's never changed in any of the hospitals I've worked with. People will always phone and say, oh, there's someone with nephrostomy to do. And actually that's key. It's all of our responsibility, and these patients shouldn't be passed from pillar to post. We should all be taking responsibility and looking after them. So we collected best practice pathways across the UK. And we combined what we felt from a multidisciplinary point of view on what we feel is the best way. And it's not one size fits all, but it's important that that's what we've done. So in the back of the framework, it's got a best practice pathway in the back of the booklet. So I've broken it down so you can all read. It starts at stage 1 when it's a multidisciplinary decision to put a nephrostomy in. So the patient needs to be consented, and it's really important the patient understands what's going on here. And I think sometimes, depending, obviously, if it's an emergency, some confusion can happen. In the leaflet, in the framework, it has appendix sections. It has a patient leaflet information, so you can take that out of it, print it. You know, if you have to get it rubber stamped through your ICB or your hospital, then you can use that as an example. You can edit it, but there's examples in the framework. Now, there is a nephrostomy passport. We use these for catheters. We should be using these for catheter care. And everybody felt this was a really important way of ensuring communication between multidisciplinary teams. It works with patients. It's, you know, like a mums with labour books. It's like the catheter passports. It's really good to have between primary and secondary care with different computer systems. It's to improve and ensure patients and whoever's looking after the patient understands what's happened. And by that, I mean the date of insertion of their nephrostomy, the type of nephrostomy, and the product code for nephrostomy bags. Because I think Lauren can probably definitely tell some stories around that.
Yeah, I was just smiling there because it is a lot of the time with products, especially when it comes to nephrostomies, is they'll say you'll get patients, healthcare professionals get stuck because they don't know what the product is, and when you have to order something, you need the product code. And often, if you're ordering with GPs or through pharmacies, etc., you'll say a nephrostomy bag, they don't know. They're like, I don't know what that is, let alone a code. Whereas you say, I want a catheter, they'll just find the formulary and go, yeah, that's fine, we'll go for that one, or whatever pops up. Whereas nephrostomies is always a very grey, it has been for a while, a grey area, and people don't really know. So again, that's some useful information we have we've just outlined the nephrostomy bags that are available, all the ones that are on prescription that you can order with a code. So it's all there and easy to find, which will be really helpful because that's been such a big problem.
We're saying that this stage 1 starts with IR and award. So they should be completing this part of the paperwork, this part of the nephrostomy passport, because they're the ones that actually put in the nephrostomy in. And I think that's, you know, with whose responsibility? Well, it should be their responsibility. It shouldn't be the nurse that's doing the discharge at the end that's trying to find out. It starts from the beginning. And then it's then used as a product. You know, the passport is then used to hand over to the ward staff. So they're making sure that they understand the next steps. So that would be around, I'm just having a look at the thing, making sure that the patient is well enough educated, or the carers, to be able to manage the bag. There's a nephrostomy care leaflet in the back of the framework. Print it out, adapt it to your trust or your ICB so that the patient can have that given from the ward. So this is a ward care. This is important. Everything is about where the responsibility sits. It sits with us all at different stages. It can't be all with a ward. It can't be all with IR. We have said everybody, go backwards. We have said everybody needs at least 2 weeks of supply. I think that was definitely a big question, Lauren, wasn't it?
Yeah, because it comes down to ward supply, how making sure they've got enough supply to give 2 weeks. But really, it's only changed once a week, so it's just 2 bags, dressings, etc., belt, which they should already have a belt, or it depends on their system that they're using, of course, a fixation. So yeah, 2 weeks supply isn't as much as it sounds, and it's really important because with some suppliers, surgeries, etc., it takes a while to get that product, and it needs to be changed every 5 to 7 days. So yeah, we've agreed with the 2 weeks, haven't we?
We did. There's a lot of pure faults. These are key areas for everybody. So, like I said, the nephrostomy passport is really important. It's a really good communication. We have different systems in different hospitals, in the community, primary care. So the passport helps with that communication. We have the passport on BAUN, which is the British Association for Urology Nurses, with the framework. But also, I know the Urology Association have also got the passport and the framework on their website. So it's there for you to use. There is so it's really funny when I'm doing this because it goes. everyone's head's in the way of everything. Right, so I'm trying to move everyone. This is a discharge form. If I move the right way, it's easier. So some places may be able to, I'm trying to get this put onto, we use Cerner in secondary care. And we know for catheter care, it's all on Houdini and things. So it's actually on our system. So I hopefully will manage to get nephrostomies onto Cerner as part of the discharge. But I don't want people to think that's a problem. This is something that we should all be using for discharging patients. It's a checklist. It's just a safety thing to make sure. So making sure the GP, the community nurse details, i.e. when we do a discharge back to community, if we know it. But if we don't know it, then we need to work out who's going to be managing this patient in the community. So there has to be links somewhere. So whether that's a GP and we contact a GP and ask, or whether it comes a district nurse's law, can probably fill us more into that. The nurse specialist, whether it's gynae, colorectal, urology, palliative care, there is a nurse specialist somewhere that's looking after these patients. If there's not, the wards need to find out a nurse specialist within these areas. It should have the reason for the nephrostomy going in. Patients are often discharged and they don't actually know why they've had a nephrostomy in, or they don't want to know sometimes. So it's a good way of communicating the date it went in. I mean, it's everything we've already said. In the previous thing, it's about responsibility, and you are discharging somebody from secondary care into primary care. We can't expect primary care to know what's been going on unless we do passport and a good discharge to them. Otherwise, this is where the patients are caught in the middle and they have poor experience. Lauren?
Yeah. Again, I think where things have fallen down, and you'll all know in your own areas where you've witnessed this, is again that lack of communication and some patients being discharged into the community without a follow-up booked, without district nurses booked, or if that person is independent, there is no reason why they can't go to their practice nurse. But again, this is where the education comes around as well. I know, particularly in this area, and I know having been a part of this focus group, it happens in a lot of areas. Surgeries then will say, "Oh, sorry, we don't do that," and that's more around the training element. It's something so simple and more than capable of doing it in the surgeries. It's that they don't have the training and the education around it. But yeah, it comes short when the referral's not done, and then those patients get left, and you get a call saying, because they've called the hospital back up, and then I get a call, for example, and say, well, they've had nephrostomy for 2 months, it's not been changed, because again, they just go into the abyss, and this will help resolve that, we hope, much like catheters, same principle. And fingers crossed, this helps avoid, as we said right at the beginning, as Paula said, preventable patient harm. Yeah.
So the last two stages we've done best practice is, I'm just moving you all out of the way, is it's really fun. That's it. So the passport. Well, I've got lines on the screen where I've got heads and I'm having to move your heads around, so I do apologise. So it's a passport. So it's most important is that we update the passport before. I cannot express, this was what every speciality felt was the most important. But more importantly, it was about how it is communicated to primary care. And I think sometimes I work in secondary care, we don't necessarily recognise how much pressure we're putting on primary care by just discharging somebody without this communication. The passport will help primary care with contacts if they have any concerns, the patients if they have any concerns, carers if they have any concerns. So it's got passport, it has all the details, like I've said, with discharge. We discussed multiple times how involved should a carers be. Well, actually, they should be really involved. If somebody is 32 years old with gynecological cancer and they're waiting for a practice nurse to come and change a dressing, or they're having to wait for GP pressures, actually, why can't carers change dressings? There's absolutely no reason. If you was a child or if you had a PICC line, you'd be able to do it. So there's no reason why carers and patients can't change dressing themselves. And it's also, we had a long discussion, why can't carers or patients flush nephrostomies themselves? And as long as somebody's competent and they are they are shown how to do this, and you assess them, there's no reason why they can't. And we agreed that as multidisciplinary. And there was lots of, well, we don't think that was safe, but actually no, if someone can flush PICC lines, then there's no reason why someone can't flush nephrostomy, and that was agreed amongst the group. Stage 3 is all around the logistics of discharge. It's making sure patients are discharged safely into the community, using, like I said, the discharge letter, the nephrostomy leaflet, caring for your nephrostomy, and the passport. And then we really felt there's a big part around the governance. So once patients are discharged into the community, what happens? How does somebody escalate there's any problems or recognise there's any problems? So we have done a section on when the patient should have their nephrostomy reviewed. And I think that was really important, where patients, we've all experienced it, patients have come back sort of 2 months later, 4 months later, 6 months later, they're still in a nephrostomy because they have not heard from anybody. So it's really important that they had a outpatient's appointment for a nephrostomy review by their team, and that should be in the passport before a discharge. But also there's a troubleshooting section. So it could be that the nephrostomy is not draining, but actually it's a nephrostomy higher than hooked onto a side of something, or it should be below the bladder. So just making, or below the kidney. So just making sure there's common sense or things that we just don't necessarily think about. So we have done a huge troubleshooting part as well in the back. The troubleshooting, I'm actually going to hand over to Lauren, because she is the expert in this area, probably, because she does this a lot more than I do.
Yeah, I think with troubleshooting, it's hard, isn't it? Because you'll get, as community nurses, or you're working in the hospital and on the urology ward, on the oncology ward, wherever, and you'll get a call, mainly urology, I think possibly, and it'll be a patient you've never seen, and the district nurse is calling because they don't know who else to call, and saying it's not draining, like what do we do? Or patients unnecessarily get, something, one or two things, they get left because they don't know who to contact, or they are sent to A&E when that's not necessarily the right place. Again, with the passport, I know in my trust, local trust, they don't send patients to A&E. They've got a particular, they call a number in IRU, and the doctor will call them back, or the consultant will call them back and assess, and then tell them where to go. So there's like a sort of triage. But obviously not everywhere has that. Everywhere in your areas, I'd highly recommend finding out, if you don't already know, what that protocol is, because some places are different. But as a general rule of thumb, troubleshooting common problems, I wouldn't say it's not a catheter type of catheter. It's not an indwelling catheter, a suprapubic catheter. However, the common troubleshooting problems are generally quite similar. So, for example, if they're not draining much urine, and that's abnormal for them, because sometimes nephrostomies don't drain much, dependent upon why they're in. So it's always worth working out, is that different for them? If it is, drink extra fluids like you would recommend with a catheter. Check there's no kinks in their tubing, again, because dependent on what bag you're using, or the patient's using, sometimes they could be quite long and thin and they get kinked quite easily. So always worth checking. Again, if this is via a telephone call with the patient, get them to check, make sure, like Paula said, the bag is below kidney level, otherwise it's not going to drain effectively, especially if people are keeping it on the bed overnight. Leaking from around the tube, very common problem. Again, check for kinks, make sure the bag's not full and it's effectively backtracking, it's got nowhere to go. It may need flushing or changing the tube. But seek medical advice if it continues leaking, but monitor. Increase in smell, thick urine, again, not comparing to a catheter, but trying to normalise it to things we do every day. Increase fluids. If they feel feverish, then seek medical attention, possible infection. I think we'll talk about that further down. I don't know if we do. It could be, it depends on where the pain is. We do talk about pain. We'll go back to that. Blood in urine, a small amount after insertion, again, depending on insertion, if it's emergency insertion, If it's why are we inserting it, will depend on the level of blood, but a small amount of blood is quite normal. And sometimes people are discharged with blood in their urine. And again, on the passport, you can write in the comments, you can write in there if they've still got blood and if they have an abnormal amount of blood, or that's actually normal for them because of X, Y, and Z. So in the community, you can see that and go, oh, that's normal, let's not panic. If it's heavy bleeding or clots, etc., seek medical advice. Again, as per your area. Pain and discomfort, mild soreness is obviously normal because they've got a tube stuck in their back. And again, you lay on your back quite often, or you put pressure on it so it can make it quite uncomfortable. It's the worst placement, but it has to go there. There's no choice. But it can be quite uncomfortable for some people. But if they're getting sort of shooting pains, often people describe it when there's an infection within the wound site. Or kidney, they describe it as a sharp stabbing pain, and they can't put pressure on it. So definitely need to seek medical advice. And there could be an infection around the site as well. Again, if you're changing it and you're changing the dressing and you're going in, if you notice a small amount of redness, again, normal, but obviously pus, etc., you're looking out for general signs of infection, tracking. Tube dislodgement happens. However, again, with the guidance, we hope that it will happen less, because there are advised fixation and how you would put a dressing on, what dressings you use, how you access them, codes, etc., that anchor the tube to the back. So hopefully they don't get dislodged. But things happen, they do. And if it falls out, catches, then stick a clean dressing on, or advise them to stick a clean plaster dressing and contact emergency service, contact the hospital to get it reinserted if needed.
So when to seek help. So we have done a section on, so we've done a section on troubleshooting, which helps patients and it helps the community, but also secondary care, but also when to seek help, i.e., like Lauren's just said, if they have started having fevers, feel generally unwell, their urine has changed and it becomes thick in colour, becomes cloudy, you've got an infection, they do need to go to A&E. So we put this section into the nephrostomy passport as well for carers and patients to look out for. So in so I'll go back to why we did the nephrostomy framework. We wrote the framework to help on communication, to standardise care, and I'm going to say, to give nurses, HCAs, everybody, the confidence to look after them. It's everybody's responsibility, and I cannot reiterate that more. But I think people, all of us, become scared of nephrostomies, not sure what to do, so we tend to push away. Well, actually, hopefully the passport will help us build links up with primary and secondary so that we can contact somebody. In the actual framework, we have done section, there's videos, there's QR codes, there is competency sections on how to flush, how to change dressings, what the different types of nephrostomies. So it looks really big, the actual framework, but it's not. It's broken down into sections. It's even got a section on what to think about before you go on holiday. Can I go swimming with a nephrostomy? So it's got sections on what patients all felt was really important. So you can skim some bits, but you can definitely, I would recommend everybody reading, just going through and just refreshing your mind. Think of catheters, but it is around catheter care principles. But just gives the idea, it just gives you the confidence to manage and look after them safely so that patients aren't stuck in the middle of, I'm going to say, my lack of competence to look after somebody. And I think that's the most important thing. Patients have come to harm. We like YouTubes, there are QR codes, so this will help all of you. I'm going to say, build your confidence, refresh things, and just relook at practice again. If you are worried in a community, then contact the secondary care. They're happy to go through things and vice versa. I think it's really important we start building bridges and build this communication better between us all. Anything, Lauren, to add?
Yeah. I think as nurses as well, which we've said before, I know speaking for myself, especially if you're lone working, again, out in the community, you're often out by yourself, and it gets drilled into your head, or as a healthcare professional, like, don't go outside your practice, like you'll be taken to court, and we worry, and that's good. It stops us doing things that are harmful to patients. But if we've got something that is in black and white, like this framework, that we can follow, and we know it's national guidelines, everybody's following it, or should be following it, it's something to go by, and we're not going to get in trouble for doing that. And it's information for us to look at, and I hope that will help, and especially, as you say, Paula, bridging the gap between secondary and primary care with the communication from the passport, with all of this information. Everybody's following the same stuff. We're not doing something different from one hospital to the other, which is currently what's happening. So yeah, I hope, and there are so many helpful YouTube links, isn't there, and QR codes and things you can just quickly check, because I appreciate none of us have all the time in the world to go through a really long document, but it is, as you say, Paula, it's broken down into really helpful sections. It looks long, but it's got some really useful stuff in there that's really quick 2-minute clips that you can take off to your ward or to your area and show people. Yeah.
Okay, thank you.
Okay, Paula and Lauren, thank you very much indeed. Paula, can you just stop sharing, do you think? And then then I can have everybody back in the main room. Brilliant. Okay, thank you very much. We have a very short period of time. Thank you so much to those of you who have been using the Padlet and putting questions up there. As you can see, it is relatively simple. You just click on a post-it note, write your question, and then please put your question up onto the Padlet. That will remain open after today's webinar. So we probably won't have a look at that and probably until the end of the week. So if you go away and reflect on this, or have a chat with colleagues when you get back, when you go into work tomorrow, you might be keen to put some questions up there. We have a few minutes for any of you to share any thoughts and reflections. At the end of this, I'm just going to ask Lauren and Paula just to make a few comments, but this is your chance to share anything you would wish to share following that presentation. If you use your raised hand button at the bottom on React, there is a little yellow raised hand button, which I am demonstrating now. If you put that up, then I should be able to see you. We really don't want any of you to walk away today going, oh gosh, I wish I'd said, or I was really interested in. So this is your chance to do that. So over to you. Hopefully somebody will go. I'm scanning my screen. Hey, Laura, over to you. Laura, don't forget to unmute yourself.
Here I am. Thank you, ladies. Thank you for tonight. It's been really informative. I have transferred from community nursing to GP land recently. We have a tiered system for wound care. And currently in Doncaster, as far as I'm aware, nephrostomy sit at tier 3, so only certain GP surgeries will provide that wound care. Otherwise, it goes across to community nurses. And that's often where we find that patients end up in a spiral, because patients are not housebound, therefore the community nursing teams will not see them because they will not sit at home all day and wait for a visit. And they end up in that spiral that you spoke about, where they end up in A&E when they shouldn't do. It's not a question. This is where, like you say, locally where the system is falling down.
Great.
And I think, like you've said, we need to look at self-caring a lot more. So tonight will have helped me in that respect, so to speak.
Laura, thank you. Can I ask you not to respond, actually, just because I'm conscious there are other people. But Laura, thank you very much indeed. Fantastic. I'll give you a chance at the end just to respond to the questions as a whole. Nuna, over to you.
Oh, hi. I just wanted to say thank you, because just having this framework is going to make a big difference.
Great.
It's just something that we've been totally missing. I think individually we've all been trying to make some like passports as such, or some patient information, but having something that's actually national and it's guidelines like that. We can all go onto YouTube, but unless it's sort of been verified, it's very hard sometimes to if you're working in small teams as well, to actually get the right information across to the patients and to help your colleagues in the community as well. So I just think this is really good. Brilliant.
Great. Anybody else got any? Yeah, Jackie, over to you. Gosh, I said that and your hand went up. That was beautiful timing. Over to you.
Yeah, just in the back of it, none of us was saying there. I'm not involved in where the nephrostomies are put in, but knowing that, excuse me, knowing that framework's there, I'm going to take that back to the areas that do, to say, are they aware of it? Is it going to be any use to anything that they're doing? And even actually over at the ward side as well, which we do work quite closely with. So it just says, are they aware of this framework? Again, I'm not sure if we're using a passport. Is that something that should be introduced? Just it raised a few questions, and just it's good for it to be able to take things back to maybe help your own areas, but also inspire other areas, or just make sure we're all, following a really good practice and good pathways. Yeah.
Jackie, thank you very much indeed. Anybody else got any kind of thoughts, reflections, comments? We don't want any of you to go away going, if only I could have said. So anybody else? Naomi, over to you. Naomi, you're on mute, so could you unmute?
The joys of technology. And it was indeed. Absolutely. Thank you very much. Amazing session. It was just to ask Lauren, is there any contact details, or can people contact her if they need support?
Yeah, I presume we'll put that's on. I presume that'll go into the chat or in the presentation. Fabulous. Okay, anybody got anything else before I just return to Lauren and Paula? Any other thoughts or comments? Thank you for those of you who've been putting some comments into chat. And don't forget the Padlet's there for questions, and both Paula and Lauren will be reviewing those. So please make sure your questions are up there. Okay, Paula, Lauren, over to you for the final word before I pass to Brian to close the webinar.
I mean, my main word is I really hope it was done. We wrote the framework because patients were coming to harm, and you're absolutely right, Laura. Patients are just caught between secondary care, primary care, GP world, but I think patients were coming to harm personally because we're worried about the nephrostomies ourselves. So I think if you look at the framework gives people the guidance, how to. Everyone can flush, and people go, I'm not sure I can, but actually you can if you get the competencies. If you're in a community, you can always ask secondary care to help you, assess you. Patients should not be going to A&E for 5, 6, 7, 8 hours for no reason. It's a terrible experience, especially if it's end of life, and I think that's really important. So hopefully this will just bridge primary, secondary care, community care, and improve communication. It's a problem nationally, it's everywhere.
Great, thank you. And Lauren, over to you.
Yeah, echo everything that Paul has said, and thanks for everybody that put their hands up and said some bits. And it's hard not to react because it's what you were saying, Laura, about GP land is baffling, and no wonder people get stuck in that, like you're saying, that spiral. But hopefully this will encourage things to go forward and objects to not be put in the way like that, because we can't leave patients. It's awful, like you say, Paula. People end up in A&E when they really should not be in A&E. And for everybody that commented, there are helplines, there are additional support that can be offered to patients, to healthcare professionals as well, not just patients. And we'll send out, again, that'll be answered in the Q's and A's, but also in links we can send out. But everything Paula said, plus that. But thank you for joining as well. I really
Paula,
appreciate it.
Thanks, Lauren. Paula.
Yeah, can I just say one thing?
Of course,
Secondary care have an obligation to try and roll this out in their trusts, because if you're not rolling it in secondary care, it will never reach primary and community anyway. So we have to make sure it starts in IR, goes to the ward, and goes to the specialities. Otherwise, it's going to be another policy that sits on someone's shelf. So I do think secondary care have a huge responsibility of trying to roll this out.
Paula and Lauren, thank you very much. And thank you. I know how frustrating it is when somebody says, please don't answer that. I was watching the clock tick away and I thought, no, let's make sure. So thank you very much. And thank you. That was a really great presentation. Brian, over to you to close the webinar.
Yes, thanks, Liz, and thanks, Laura and Paula, for the talk. I just want to put in perspective why the Urostomy Association have got involved in this. We started getting calls on our helpline because people were struggling to find information about nephrostomy help. So we thought we would start and look and do some work on that. We have set up a page on our website of resources for this, and we'll put that information in the email that we send out when we get back to you about how to access the recording of the session tonight. So we're also talking to sister organisations to enhance that facility that we're offering to patients. We've been providing help and support to urostomy patients now for 50+ years, so it's a strong learning curve to go through for nephrostomies, but we'll get there, and we want to help patients that are out there that are struggling. So when you log out tonight, there will be an evaluation form. If you wouldn't mind filling that out, please. It does help us to improve as we go along, and to see if we've done the right thing to help you guys out there in the field. I'd also like to thank the speakers and Vine for sponsoring the event tonight, and also to Liz, Scott, and Samantha for putting all this lot together. As I say, there is the resource part of the website, and there's an article on there that's recently been put up about an interview that we've done with a couple of patients to give their views on how they've handled their nephrostomies. So thanks everybody for coming along. I hope you've enjoyed it, and we'll look at doing further ones in the future. So keep posted, and we'll let you know when something else is coming up. So thanks very much indeed. Bye bye.
And have a good evening, everybody. Thank you. Bye bye.